aims of this session from me is to obviously discuss the referral assessment process for liver transplantation for patients, to discuss what happens at the transplant listing meeting where we make the decisions regarding putting people on transplant waiting lists, to talk a little bit about the transplant waiting list and how people manage while they're waiting. And also, if time's permitting, I'm going to talk about how, when we get offered livers and organs for transplant, how they match best with the recipients. And also a little bit about recovery and critical care and post-op and clinics. So we've had a liver transplant unit here in Birmingham QE Hospital since 1982. And in the early days, it was very small. We only did 3 transplants in our first year of transplants. And, you know, things have grown since then over the years. And in fact, last year we did 200 transplants, adult transplants in the QE. With our paediatric transplants, we transplant at Birmingham Children's Hospital up the road, it was nearing 250. So that was our biggest year, and we are one of the biggest transplant centres in the UK. Now, historically, our patients have been assessed for liver transplant over a week as an inpatient. So, you know, with the new QE hospital opening, we lost beds. You know, lovely big hospital, but 2 hospitals were merged and we ended up losing inpatient beds. So because of that, we had to look at a revolutionary new way of assessing patients for a liver transplant. So initially, we started off with just 2 patients each week, and they had to be fairly fit, well patients with no complicated comorbidities or other illnesses going on. And you may think, well, how come liver patients are fit and well? Well, some are, especially those with maybe hepatitis C who are not ill with their liver but have got an associated hepatocellular carcinoma, and that's the reason why we're assessing them. However, things have grown over the last few years. We started that in 2011, so in the last 5 years that process has actually grown, and we now regularly assess each week via an outpatient basis 6 patients each week. So that's an awful lot of patients that go through the system. There will always be a need for inpatient beds. We have a lot of patients who are so sick that they are very encephalopathic, whereby they're very sleepy, drowsy, or even aggressive, and they cannot sit for hours at a time or attend an outpatient for many hours at a time to go through the process. Also, you may remember seeing Dr. Holt's picture of a very end-stage liver patient with huge ascites and very thin arms and legs. They're patients who cannot physically go through the process as an outpatient. And we sometimes get hospital-to-hospital transfers where patients come in and then we decide to assess them for liver transplant. So how does the process begin? Well, we get referred from all over the country, really, patients who are in need of a liver transplant. So they're managed locally, maybe for many, many years with their disease process, and it reaches a point where, you know, transplant is mooted, that their local physicians feel that a transplant is the best way forward for them. And again, as Dr. Holt elicited, sometimes the patients get referred very end stage, whereas perhaps if they were referred earlier, we could perhaps manage their disease process a little bit better and maybe put off the need for having a liver transplant, but not always the case. So they're seen by one of the hepatologists in clinic, and we've got many hepatologists here at the QE, and most of them specialise in different areas. Some specialise with alcohol-related issues, some with metabolic issues, some with viral hepatitis issues. And so they're usually slotted into a particular hepatologist. If that hepatologist then feels that there is nothing more medically we can do to control their symptoms or the progress of their disease, then they may be referred for a liver transplant assessment. And at this point, it is only assessment. And we often get patients pitching up to us who think, right, I'm coming in for my transplant now. It's a done thing, I'm going to have it. Well, no, it's not the case. Just to show you over the years how things have grown with the referrals and the assessment, it is an ongoing and increasing problem now. Liver disease within the UK, again, has been already mentioned today. So the outpatient route, as saying the first year we did 188, last year we did 282 assessments. So this is just assessments. Via the inpatient route, that first year 98 and last year 144. Now obviously resources are slowly being put in place, but what's normal within the NHS is that resources lag behind the need. So we're still trying to build resources to enable us to assess more patients. Super urgent, this is a category of liver patient where they have suddenly become very ill with their liver disease, and it's people who have maybe taken a paracetamol overdose. So the super urgent listing is a special part of the transplant waiting list, which only 1 or 2 or 3 people at any time are on the list, and it is reserved for those who have had no illness, no chronic liver disease and no symptoms for the previous 8 weeks, but have suddenly decompensated for whatever reason. It may be, as I say, due to paracetamol, it may be due to a viral hepatitis, or it may even be due to drugs. I don't necessarily mean illicit drugs, I mean not over the counter, but prescribed drugs. So again, that is on the increase, but those patients don't go through a formal assessment because there isn't time. They are just put onto the list and get transplanted within a few days. Okay, so patients being transplanted. Having a liver transplant is a very big, complicated operation. And patients don't just come to us with their liver disease. They may have other illnesses, conditions, which may affect the way that we do things or even prevent us from being able to offer them a liver transplant. So we have to investigate them very carefully. So all patients go through the basic investigations. They'll have a chest x-ray, which obviously looks at the size of the lungs, the shape and size of the heart, and to look for any pathology that may be in the lungs that's previously undiagnosed. They have an abdominal ultrasound scan, and with that we're looking at the liver, the structure of the liver, the blood flow through the liver, and we also look at the kidneys as well. They have a 12-lead ECG, self-explanatory, look at the rate and rhythm of their heart. They have an echocardiogram, which looks at the structure of the heart, the blood flow through the heart, and the pressures within that system as well. They also have spirometry, where we're looking at their basic lung function to make sure that they've got good lung function. They also then have an initial interview with the liver transplant coordinator, and we go through the whole process of a liver transplant assessment so they know what to expect. There is a lot of education and information giving that we give to the patients and their carers, relatives as well, because the family or carers or relatives will be part of the process of them going through a liver transplant. They also have blood tests done. We look at their liver function. That seems obvious, doesn't it? But we look at their liver function. We look at their haematology and their clotting as well. We look at their renal function. We look at their immunology, especially in patients where there is perhaps not a clear diagnosis to their liver disease. So it could be one of the autoimmune diseases that is causing a problem, and these immunology markers will help us at least try and pick out what could be happening with the liver. We look at virology. So have they had or have they been exposed to things like hepatitis A, hepatitis B, hepatitis C, CMV, HIV? Now, having had any of those viruses doesn't stop them going on a transplant waiting list, but it's information that we need to know because, again, it can influence how we manage the patient. Blood group is very important. And we do 2 separate blood samples to elicit blood group because mistakes do happen and we have to make sure that we have got the right blood group for the patient. In patients where alcohol is an indicator of their liver disease, we do an ethanol level as well. And patients usually are alcohol-free for at least 6 months, though this is not always possible. But that's a stipulation we like to have, that they're alcohol-free before they come for a liver transplant assessment. So we get all those investigations done. They go away. So all this takes place over 1 day. They go away. And then we get all the results back and they are discussed with one of the consultant hepatologists. And he or she may say, right, we've discovered something on a basic scan that we need to look into in a bit more depth. And so they may go on to have things like CT scans or further blood tests, whatever is needed. So we then book for them, usually about 3 or 4 weeks later, to come back to the hospital for 2 consecutive days. And they don't stay as inpatients on the ward. They come to a designated area that we've got, which is fairly comfortable. We've got nice soft chairs, we've got refreshments, we provide a little bit of light lunch, there's a TV and, so on and so on. But they have to find their own accommodation. We do have some accommodation, but again, they have to pay for that. And, some of these patients, unfortunately, are not working. They may be on disability benefits or they may have other problems, where they can't afford it. So that can be a big burden for them. And don't forget, they're travelling many, many miles from Wales, Liverpool, all around really. But on the first day, we start with education and we have PowerPoint presentation where we go through with them the whole transplant process. Now, we say to them, it's not like having your appendix out where you come in, have your operation, a couple of days later you go home, a few weeks later you're feeling well, and that's it. It's a lifelong thing for them. And we say to them, we need to let you know the good, the bad and the ugly of having a liver transplant because it doesn't necessarily cure them. It may swap one set of problems for another, in that some of the drugs that they're given can have some serious side effects, like becoming diabetic, like developing cancers, hypertension. But hopefully it will get rid of some of their more severe symptoms and maybe even stop them from dying from their liver disease. So that takes place over, a couple of hours really, and they have a big book as well to accompany this. So we talk about donation, where we get donors from. We talk about going onto a transplant waiting list. We talk about how we contact them, how we get them to Birmingham when we get a liver for them. We talk about the operation. We talk about recovery in critical care, the ward, clinics and lifelong follow-up. And it's important that families are present as well to hear this because they are part of the process and they will be part of the patient's recovery post-transplant. They're seen by one of the consultant surgeons who will talk to them about the actual transplant operation itself and will quote mortality. Now, for the vast majority of patients, 75% of patients are alive and well after 1 year. But that means 15% of patients may not be for one reason or another. And that's, worldwide figures. And we're pretty well up there with the world. They'll probably get them to sign a consent form for the operation at the same time so that if they do go on the transplant list and we call them in for transplant, we don't have to worry about getting consent sorted. They'll see one of the consultant hepatologists as well, who will go through everything with a fine-tooth comb and make sure we haven't missed anything, or if we need to investigate anything further that hasn't been picked up by the original hepatologist who reviewed their initial investigations. They will be seen by one of the transplant consultant anaesthetists as well. Now, we have a group of very dedicated and specialist anaesthetists here at the QE who have worked with getting people through transplant operation. And there are various stages in the operation that are more critical and potentially dangerous than others. And they are very good at teasing out things with the patient, with their health and their general history as to what we might need to tweak to make things as safe as possible. If alcohol has been an issue, or indeed if intravenous drugs in the past, no matter how many years in the past, have been an issue with the patient, they will be seen by the addiction psychiatric nurse who specialises in the alcohol issue. And she will delve quite deeply into their history. So she'll go back as far as when they were at school, their family life, their work history, what's going on at the moment, what makes them drink, what stopped them drinking, what help and support is in place. And she will make a judgment call based on what she gleans from the patient as to how risky they are of returning to alcohol after a liver transplant. Now, quite a lot of our patients where alcohol has been an issue, they've been too ill to continue drinking. They may have been in hospital a long while where they don't have access to alcohol. And we need to know that when they're back in normal society, doing normal things, that they're not going to return to drinking alcohol. So that happens over the first day, and it's quite a long day for them, about 8-9 hours. Day 2, any additional tests that may need to be done will be done, either on day 1 or day 2. So extra scans, extra blood tests that may need to be done that the hepatologist has identified. And that's when we'll do the second blood group as well. They'll see the dietitian. And dietetics, is very, very important. And as you're hearing, good dietetic input really helps our patients because they often come, with ascites, they will have muscle wastage, they may not be eating very well, they may not have very good appetites, and so, they need all the advice that they can get. And in fact, good dietetic input can really improve a patient's fitness for going through a liver transplant. They see research nurses as well. There's lots of research going on at the QE into liver transplantation, and they are invited to take part in research, but they're not obliged to, they don't have to, and it doesn't affect their eligibility for a transplant or the way that we look after them. They meet somebody from the liver patient support group. Now, I often say to my patients, I've been in this business many, many years, as you can tell by the grey hair, but I've never been through a liver transplant. My family has not had to cope with somebody going through a liver transplant. The liver patient support group is made up of people who've had transplants or who have supported somebody going through a liver transplant. So they are vital to the education because they can, tell the patient what they found hard, what they found easy, and the difference it's made to their lives. They then have a final interview with the transplant coordinator, and we will finish off all our paperwork. We will know contact numbers, travel arrangements, who's going to be supporting and looking after them after a liver transplant. And we will answer any questions that need to be answered. They may have learnt things over the 2 days that they weren't sure of, and, we have a personal interview with them so that if they don't want to ask questions in the group, they can ask us in private. So the patients then go away. And then the next day, we have a transplant listing meeting. It's a multidisciplinary meeting made up of surgeons, hepatologists, anaesthetists, dietitians, the addiction specialist nurse, transplant coordinators, and any other interested parties. Because especially if a patient has got, say, a cardiovascular problem that may impact on how we do a transplant, we'll invite specialists along to have their input as well. So it can be quite a heated discussion at times, and what needs to happen is that there is a consensus and agreement from the whole team as to what we're going to do with these patients. So it may be that everybody's in agreement, that a transplant is indicated, there are no factors that we need to look into in any more depth, and a patient is accepted to go on the liver transplant waiting list. It may be that they're not accepted. They're either too well and we can manage their symptoms better medically, because what we have to weigh up is the risks versus the benefits of doing a transplant. They may be too late. They may be at a real stage in their liver disease where we cannot safely get them through a liver transplant. And that can be very hard for patients because there's not any other option for them sometimes. And so we then do go down the palliative care route. But what we have to weigh up, as I say, is the risks and benefits, but also we have to look at the fact that we're going to potentially use a liver, which is a rare resource, to transplant somebody who may not eventually make it. Very hard decisions to make. So we're looking at comorbidities as well. So just because somebody may have a degree of heart disease or diabetes or maybe obese or maybe smoking, you know, it's not to say that we wouldn't necessarily transplant them, but we have to have measures in place to be able to get through safely. It may be that once we've discussed everything, somebody may pipe up and say, well, actually, we should be looking at this in a bit more depth. And so in order to safely put them on the transplant list and get them through a transplant, we may request further investigations. It's usually to do with the cardiovascular system. So the patients are then informed. We telephone them and they're waiting for that call. We telephone them that day and we inform them what's going to happen to them. Go on the transplant list, not. If not, why not? You know, are we going to do further investigations? And we back that up, obviously, by a letter as well, which goes to their GP and their referring consultant. So this just shows the pathway, you know, of going through a liver transplant. So they start off, obviously, referral, assessment, and some patients are suitable to carry on the assessment to day 2 as an outpatient. Some may not, and they may end up going as an inpatient onto the ward to continue their assessment, and then presented, accepted or not accepted. This slide here just shows you over the years how in the orange the inpatient assessment, so where they're assessed over a week on the ward, has decreased over the years, but the outpatients in the green has increased. And it's been a challenge for us all to do that, and we were the first centre in the UK to assess liver transplant patients via this route. We sought advice from Australia, where they have done it before, and in fact we have visitors from all over to come and see how we do it, because they want to set it up in their regions. It saves the trust an awful lot of money, because you haven't got a patient staying in hospital for 5 or 7 days. So, the transplant waiting list then. We say to our patients, it's not like a list where you go to the bottom and wait for everybody above you to have a liver transplant. And each transplant centre, and there are 7 liver transplant centres in the UK, hold their own list of patients, so they're not competing with the whole of the country. We list people according to their blood group, first of all. So all blood group O's together, blood group B's, blood group A's. And then they're also listed on a score called UKELD. And that is a score that is calculated on their bilirubin, their INR, their creatinine and their sodium. And that gives us a score. And the higher the number, the worse their liver disease is, and the higher indication there is for having a transplant quite quickly. So those with a higher UKELD score are going to be nearer the top of the list, and we have a priority and an urgent, which I won't go into too much, but the priority is where the sickest patients are. And those with a lower UKELD score go nearer the bottom of the list. And patients get very hung up on where they are on the list, but we say to them, look, it's academic really, because when we get an offer of a liver, we have to match best with the recipient. So even though you're quite high on the list, a liver may not be offered to you because of donor issues and donor demographics. How long are they going to wait? How long's a piece of string? As soon as they go on the transplant list, they could get offered a liver next day, or it could be over a year. And for certain groups of patients, they're on the list potentially for 2 or 3 years. And that is very, very hard. They're seen in clinic regularly, sort of every 6 to 8 weeks or so here in Birmingham, just so that we can keep an eye on how they're progressing or not progressing. And that UCALD score is recalculated because their score can go up if they're deteriorating and therefore their position on the list can go up, or it can go down and therefore their position go down. They may receive other therapies whilst waiting, especially those with hepatocellular carcinoma. We can do other things to try and eradicate the tumour or slow its growth, but it's not a cure, it's just a holding measure. And unfortunately, some of those other therapies can then make a transplant operation itself a little bit more technically difficult. So again, it's weighing up the benefits against the non-benefits really. So, to facilitate a liver transplant coordinators, we do an on-call service, okay? And we provide 24-hour cover, and we accept offers from donor coordinators who work with donors, and we discuss with the consultant surgeon on call. And we get a lot of information about the donor, their blood group, their height, their weight, their girth, BMI, what their cause of death was, liver function tests, renal function tests, blood gases, past medical history, virology. And because of that, we then have to, well, we don't, the surgeons do, thank God we don't, have to match up who that organ would be best suited for. And it's not an easy job, which is why those on the top of the list may not necessarily get an organ quickly because of the livers we get. And so we then arrange for a team to go out to that hospital where the donor is to retrieve the organs, and we arrange the recipient operation. So we have to get them in, organise theatres, beds, etc. And as it says there, there is a huge team of people and resources behind facilitating a liver transplant. And so, it's not an easy thing to do, but it's one that we find highly rewarding. And in fact, patients do benefit. Some don't make it, but very few don't. And the vast majority of patients do make it. And when we see them in clinic, maybe 4, 5 months later, you don't recognise them. You recognise the relatives, but you do not recognise the patients because they have changed physically from what they were. I hope that's given you a bit of insight into assessment of a liver transplant patient. Thank you.